You know that feeling, right? That really unsettling sensation where you're just standing still, but suddenly the room feels like it's spinning wildly around you.
Yeah, it's jarring, that false sense of motion. Lots of people experience it, but maybe don't quite get what it is.
Exactly. We often just say dizziness, but that specific spinning feeling, that's vertigo. And today we're doing a deep dive into it.
We're using a set of revision notes as our guide here. Pretty condensed stuff designed to give you the essentials.
Yeah, think of it like a high-yield summary. Our job is to unpack these notes, pull out the really important bits, and hopefully leave you with a much clearer picture of vertigo.
We'll walk through the main ideas, flag what's crucial, and try to build a framework that makes sense and sticks.
Consider it your shortcut to getting a solid grasp on vertigo. Ready to jump in?
Let's do it. So first things first, the definition. What is vertigo, according to these notes?
Okay, so fundamentally, it's not just any dizziness. It's very specific. A false sensation of spinning or rotational movement.
Right. Either you feel like you're spinning or the room, the environment is spinning around you. That rotational part is absolutely key.
And the notes say it often comes with balance problems, too. Which, well, makes perfect sense, doesn't it?
Totally. If your brain's getting signals that everything's rotating, standing steady is going to be tough.
So, what's the mechanism behind it? The notes mention a mismatch. A mismatch between signals from your vestibular system, that's your inner ear balance system, your vision, and your somatosensory system, like feedback from muscles and joints.
Yeah, that mismatch idea is central. Normally, those three systems work together, sending consistent information to your brain about your position in space.
But if they start sending conflicting messages, maybe the inner ear says, moving, but your eyes say still.
Exactly. The brain gets confused by the contradictory data and interprets it as motion that isn't really happening. That's the vertigo sensation. And that's what makes it different from just feeling, say, lightheaded or generally unsteady. Those are types of dizziness, sure, but vertigo is specifically that spinning.
Okay, got it. So if it's about a mismatch, what causes that mismatch? The notes break it down into two main camps. Peripheral and central. This seems like a really important distinction.
Absolutely fundamental. Peripheral versus central. So
Yeah.
peripheral causes relate to problems in the inner ear structures themselves.
Right, the actual balance sensors in the ear. If the problem's there, it's peripheral.
What kind of problems are we talking about?
Well, the notes list a few common ones, things like BPPV, benign paroxysmal positional vertigo. That's where those tiny little crystals in the inner ear get dislodged, right?
That's a really common one.
Then there's vestibular neuritis, inflammation of the balance nerve, often after a virus, and Ménière's disease, which is a chronic inner ear condition.
Okay. Other peripheral ones listed?
Yeah, also things like labyrinthitis, inflammation of the inner ear structure itself, ototoxicity, which is damage from certain medications, even motion sickness fits here, and herpes zoster affecting the ear, all inner ear related.
Got it. So that's peripheral, the inner ear. What about central?
Central means the problem is in the brain. Specifically, the parts that process those balance signals, like the brainstem or the cerebellum. The signal gets sent okay, maybe, but the processing goes wrong.
And these central causes sound like they could be, well, more serious.
Yeah, potentially. The notes list things like cerebrovascular disease, problems with blood flow in the brain, like a stroke affecting balance centers. Migraine is another big one, what they call vestibular migraine.
Right.
Also, multiple sclerosis and sometimes brain tumors, like an acoustic neuroma near the balance nerve. Oh, and alcohol intoxication that definitely affects brain processing.
Okay, so a quick way to remember the difference.
Location, location, location. Peripheral. Think cardocytes. Parts of the inner ear. Central. Think computer, the brain. Inner ear issue versus a brain issue. That's the core distinction.
Makes sense. And building on causes, the notes mention risk factors, things that might make someone more likely to experience vertigo.
Yeah, like a history of inner ear problems already, previous head injuries, being prone to migraines, taking certain meds that can affect the inner ear, and significantly advanced age.
We'll come back to that age link when we look at the numbers because it's quite striking. But first, pathophysiology. How does this dysfunction actually work?
It basically circles back to that mismatch idea we started with. The notes say it's about dysfunction or damage somewhere in the vestibular system.
Which includes both the inner ear sensors and the nerve pathways connecting them to the brain.
Right. And when that system isn't working properly, it sends inaccurate signals about position and movement. The brain gets this faulty data.
And interprets it as spinning, even when you're perfectly still. That's the vertigo experience in a nutshell.
Okay. But sometimes people feel dizzy in other ways, right? Not just spinning. So distinguishing true vertigo is important.
Crucial. That's differential diagnosis. The notes point out other things that cause dizziness but aren't vertigo.
First up is presyncope, that feeling like you're about to faint, lightheadedness.
Yeah, the notes link that usually to a reduced blood flow to the brain. Could be cardiovascular issues, maybe anemia,
Yeah.
like when you stand up too fast sometimes, that kind of feeling.
Okay. Then there's disequilibrium.
This is more about feeling unsteady, wobbly, off balance, but without the spinning sensation. The notes suggest it's often due to poor information getting to the brain about body position, maybe from nerve damage like peripheral neuropathy or vision problems. Interestingly, some vestibular disorders can cause this instability instead of spinning.
Right. And psychogenic dizziness.
Linked to psychological factors, think anxiety, panic attacks, hyperventilation, driving that dizzy feeling.
And finally, just general neurological conditions.
Yeah, issues affecting the brainstem or cerebellum, the coordination centers. These can cause dizziness or unsteadiness, but again, typically not that specific rotational vertigo feeling.
So a way to keep these different types of dizziness straight.
Maybe think about the main system involved. Presyncope, heart and blood flow. Disequilibrium, often nerves or eyes. Psychogenic, the mind. Other neurological specific brain areas. It helps broaden the focus beyond just the inner ear when someone says, I feel dizzy.
Good tip. Okay, let's talk numbers. How common is this really? The notes have some UK-based stats.
And they say it's common, seen frequently in primary care across all ages. It's definitely not some rare thing.
No, not at all. Get this. About a third of people going to their GP complaining of dizziness actually turn out to have true vertigo.
Wow, a third?
Yeah, and in the general population, about 7% of adults reported having true vertigo in the last year. Lifetime prevalence is estimated somewhere between 3 and 10%.
But here's the kicker, the age thing you mentioned earlier.
Right. The notes really stress this. Prevalence increases significantly with age. It can reach up to 30% in people over 60.
30%,
Yeah.
nearly 1 in 3 older adults. That's huge.
It really is. It highlights why understanding vertigo is so important, especially with an aging population. Falls risk, quality of life. It's a big deal.
Definitely. So, given how common it is, knowing the clinical presentation, what it actually looks like, is key.
The main symptom we've established is that perception of spinning or rotation, but the notes emphasize looking for accompanying symptoms too as they help figure out the cause.
Like what?
Nausea, vomiting are common. Feeling unsteady, difficulty balancing, just a general sense of disorientation.
Okay. And the notes mention something about presentation in older people.
Yeah, a really important point. Older individuals might not describe it as clear spinning. They might just say they feel generally dizzy or unstable. So getting a really clear history is vital. You have to probe. Is it spinning or feeling faint or unsteady or lightheaded? Pinpointing the type of dizziness is step one.
Absolutely. And beyond the dizziness itself, asking about associated symptoms is critical for diagnosis.
What kind of associated symptoms are we looking for?
The notes divide them up. Are there ear symptoms, like hearing loss, tinnitus, that ringing sound, or any discharge from the ear?
Okay, ear clues. Or are there neurological symptoms? These are potential red flags.
Exactly. Things like headache, especially a new or severe one,
Yeah.
double vision, or other visual disturbances. Any weakness. Problems with coordination, like ataxia.
Got it. Neurological red flags. What else?
Autonomic symptoms, nausea, vomiting, sweating, palpitations, and sometimes symptoms that feel like a migraine aura, maybe visual or even olfactory.
And then the medical history is obviously important too.
Hugely. The notes list key things to ask. Did this start after a recent cold or ear infection? History of migraines? Any head trauma? History of labyrinthitis? Any ear trauma?
Also, anxiety or depression. Cardiovascular risk factors. Are they taking any medications known to cause dizziness? What about alcohol? All relevant contexts.
Then comes the examination. What do the notes suggest focusing on?
A general neurological assessment is mentioned, looking closely at the ears, and crucially, checking the eyes for nystagmus.
Yes, nystagmus, those involuntary jerky eye movements. Why is that so important?
Because the pattern of nystagmus can give really strong clues about whether the problem is peripheral, inner ear, or central brain.
Makes sense. And specific tests.
The Romberg test for balance. And the notes specifically highlight the Dix-Hallpike maneuver.
Right, that's the one for BPPV, isn't it? You move the patient's head and body in a specific way to try and provoke the vertigo and see the characteristic nystagmus.
Exactly. It's both diagnostic and, as we'll see, therapeutic for BPPV. The head impulse test is also mentioned that helps differentiate peripheral from central causes. And the Unterberger's test, where the patient marches on the spot with eyes closed, can indicate labyrinth issues.
Okay, so you put all that together. The description of the dizziness, associated symptoms, history, exam findings including nystagmus, and those specific tests.
And that's how you start to figure out if it's likely peripheral or central. The notes list specific features pointing towards each.
So let's try a quick scenario based on that. Imagine someone comes in with sudden, really intense spinning vertigo, but they also have a new, severe headache unlike any they've had before. They're clumsy and uncoordinated, and their vision is blurry. Peripheral or central?
Ooh, okay. Based on the notes, those associated symptoms, the severe headache, the coordination problems, ataxia, the visual disturbance, those are definite red flags pointing strongly towards a central cause, something affecting the brain.
Right. If it was just the spinning, maybe with some hearing changes or nausea, you'd lean more towards peripheral, but those neurological signs really shift the balance.
That combination is key for guiding the next steps, which brings us to investigations.
And here the notes have a really clear message, especially for primary care.
Which is?
In most straightforward cases, particularly those clearly pointing to peripheral causes like BPPV, no investigations are usually needed.
That's important. Diagnosis is often clinical. You don't just automatically order an MRI for dizziness.
Exactly. The investigations listed audiometry for hearing, specialized vestibular function tests, CT or MRI scans. Those are typically reserved for secondary care. They're used when a central cause is suspected, or if the diagnosis is uncertain after a good history and exam, or if things aren't getting better.
So things like an EEG for suspected epilepsy or a lumbar puncture for MS possibilities, those are specialist investigations based on specific red flags. Rule of thumb, history, and exam first. Investigate selectively, usually in secondary care.
Makes sense. Okay, let's move on to management, the absolute key principle from the notes.
Treatment depends entirely on the underlying cause. You can't just treat the symptom. You need to address what's causing the vertigo.
So general approaches might include medications for acute symptoms, those repositioning maneuvers for BPPV, vestibular rehab exercises, or treating whatever specific condition is identified.
And knowing when to refer is critical. The notes list specific referral criteria, essentially. Red flags for needing specialist input urgently.
What are those flags?
Okay, severe nausea and vomiting might mean admission is needed for hydration and symptom control. Sudden, persistent vertigo that isn't brought on by changes in position that needs urgent assessment by a specialist, maybe a neurologist.
Big red flag there.
Definitely. Also, any clear central neurological symptoms or signs, weakness, double vision, coordination problems, new headache, difficulty walking, immediate referral to neurology.
What about hearing loss?
Acute deafness coming on suddenly without the typical fluctuating pattern of Ménière's disease needs an urgent ENT referral. And finally, if after your assessment the cause of the vertigo is still unclear, refer to a balanced specialist.
Those referral criteria are crucial to know. What about general advice for patients?
The notes mention practical things. Avoid driving during episodes, obviously.
Right.
Inform employers if it affects work safety. And especially for older people, discuss fall risks and prevention strategies.
And medications.
Medications like prochlorperazine or certain antihistamines can help calm down acute symptoms, the nausea and spinning. But there's an important caveat in the notes.
What's that?
If the plan is for the patient to see a specialist, they should stop these symptomatic meds about 48 hours beforehand.
So the specialist can assess the actual underlying signs and symptoms without them being masked by medication.
Good point. Then there's rehabilitation. This seems like a big part of management for many types.
Yeah, vestibular rehabilitation, VR, gets highlighted.
Yeah.
It's a program of exercises shown to be effective, particularly for ongoing dizziness or unsteadiness after a peripheral vestibular problem like neuritis. It helps the brain compensate.
The notes even mention simple booklet-based rehab being cost-effective for chronic dizziness. And specific balance rehab is key for older patients to reduce fall risk.
And for BPPV, we come back to the Epley maneuver. It's not just diagnostic, it's the main treatment. A specific sequence of head movements to get those crystals back where they belong.
So effective for BPPV. And the notes make a point about rehab versus drugs long-term.
Yes. They suggest that if a specific cause like BPPV isn't found or treated, and symptoms persist, offering vestibular rehabilitation is generally preferred over just continuing long-term antivertigo medication. Treat the cause if possible, then rehabilitate.
Okay. The notes also briefly mention Cawthorne-Cooksey exercises, which are another type of rehab exercise, and even surgical options for severe intractable Meniere's disease, but those are much less common.
So wrapping up management, nail the diagnosis, treat the specific cause, like epley for BPPV, know the referral red flags, use meds for acute symptoms short-term if needed, prioritize vestibular rehab for ongoing issues, and focus on safety.
What about the outlook? Prognosis.
As you'd expect, the notes say it really depends on the underlying cause. Many types, like BPPV or vestibular neuritis, often resolve well with treatment.
But some conditions, like Meniere's or maybe central causes, can lead to chronic or recurring episodes, right?
Exactly, it varies widely, which leads into the potential complications. Why is managing vertigo properly so important?
Well, the notes list some serious consequences. Falls and injuries are a major one, especially in the elderly.
Makes sense. What else?
Anxiety and panic attacks can be triggered by the frightening sensation of vertigo. It can significantly reduce quality of life and impair daily function, think work, driving, social activities.
Yeah, I can see how it could lead to social isolation or even depression if it's chronic and debilitating.
Definitely. These complications really underscore that vertigo isn't just a minor inconvenience, it can have a profound impact.
So let's try and synthesize the key takeaways from these notes. Vertigo is that specific spinning sensation, different from other dizziness. It stems from a mismatch in balance signals.
Causes are broadly peripheral, inner ear or central brain, and figuring out which relies heavily on the history, especially the nature of the dizziness and associated symptoms, and the clinical exam looking for things like nystagmus.
Investigations often aren't needed initially. Management must target the underlying cause, epley for BPTV, rehab for others, knowing referral red flags is crucial. Medications are mainly for short-term symptom relief.
And the prognosis varies, but complications like falls and anxiety highlight the need for proper assessment and management.
So, given everything we've unpacked, how common it is, especially in older adults, its potential impact on quality of life, safety, mental health.
It really makes you think, doesn't it? How do we shift perspective? Instead of just seeing vertigo as a symptom, maybe we need to consistently recognize it as a condition needing careful assessment and really tailored support to prevent those complications and help people live better.
Absolutely. And having a solid grasp of the basics, like the information distilled in these revision notes, is definitely the foundation for doing that effectively.
If you want to delve deeper into these notes or find more resources like this, you can check out passthemsra.com and freemsra.com.
That's passthemsra.com and freemsra.com.
Thanks for joining us for this deep dive into vertigo.